Welcome to your ophthalmology exam journey. Let's make sure you're fully prepared.
We tend to think of silicone oil as this great stabilizing force, almost like a temporary internal splint or tamponade. But really, it's a tool with an expiration date. And this image? Wow. It perfectly shows what happens when that clock runs out. What you're looking at is hyperleocrystal, and it's a crystal clear sign that the oil is breaking down and becoming the problem itself.
So that really gets us to the heart of it, the inevitable breakdown of silicone oil. Let's dig into exactly why this stabilizing force, this ticking tamponade, absolutely has to come out by looking at the cascade of complications it can set off.
Okay, so the main villain of our story is a process called emulsification. It's pretty much just physics, right? The surface tension is lost, usually because of post-op inflammation, maybe some blood or other surfactants, and our one big helpful bubble shatters into countless tiny troublemaking droplets.
Now, what's so fascinating about this slide is how it shows the two-front war of emulsification. On the left, you see the oil back in the posterior segment, where it's starting to fail at its main job as a tamponade. Then on the right, you see those same little droplets have moved forward, and now they're causing a whole new set of issues in the anterior chamber. And here's the thing, this emulsification is anything but benign. Those tiny droplets can directly cause secondary glaucoma by blocking outflow, they can cause band keratopathy from corneal contact, and they lead to pretty much universal cataract progression. This list of complications, this is why silicone oil removal, or SOR, isn't just an option, it's an absolute necessity.
This brings us to probably one of the most critical clinical questions we face. It's not if we're going to remove the oil, but when. And getting that timing just right, well, that's the surgeon's dilemma, a real balancing act of competing risks.
So, the evidence gives us a window. The classic silicone study suggested anywhere from 2 to 6 months. Most of us today aim for that 3 to 6 month window, once the retina seems stable. But look at what happens over time. A big multi-center study found that after 6 months, the risk of band keratopathy starts to creep up, and then it takes a sharp jump after 10 months.
But here's the dilemma, right? Just this year, a large retrospective study by Zhao and colleagues kind of threw a wrench in the works. They found that a longer tamponade, we're talking 10 months versus about 7, was actually linked to a lower risk of redetachment. So now you've got this real strategic tension between avoiding oil complications and preventing another detachment.
And of course, there are some absolute deal breakers. If you've got hypotonia, I mean dangerously low pressure below 6, or an unstable retina, or some really gnarly PVR, then taking that oil out is just more dangerous than leaving it in. Patient safety has to come first, so we wait.
Okay, so we've established the when. Let's switch gears to the how, because a successful outcome isn't just about timing, it depends completely on mastering the art and the science of the removal technique itself.
To get the bulk of the oil out, you've really got two main choices. Active suction is fast, it's efficient, but you have to be super careful to keep that cannula inside the main oil bubble. On the other hand, passive removal is slower, letting the infusion pressure just gently push the oil out. Honestly, both work, and it often just comes down to surgeon preference. But removing the main bubble, that's the easy part. The real challenge is getting rid of all those microscopic emulsified droplets. The two big techniques are a triple air fluid exchange, which is like a powerful flush, versus a more gentle, balanced salt solution lavage, which is more of a rinse and dilute approach. So, which one's better?
Well, we actually have a pretty definitive answer. A recent really high-tech study using X-ray photoemission spectroscopy found that AAA-FX is flat-out superior. And this is so cool, it shows us why. The eye wall isn't just a passive container. It actively holds on to silicone droplets. You really need that vigorous exchange of an AFX to get them out.
And hey, always remember, SOR is an opportunity. While you're in there, you can deal with other things. Like this slide shows, it's the perfect time to carefully peel any parasilicone membranes that might be causing traction or messing with vision. It's definitely more than just an oil change.
All right, so the surgery went perfectly. The oil is out, but our job isn't over yet, not by a long shot. Now we're in the post-op phase, where we've got to navigate potential complications and talk to our patients about what to expect.
We have to be really honest about the risks. Citing that same 2024 study by Zhao and colleagues, the retinal redetachment rate after SOR is just over 20%. That's about 1 in 5. It's the most significant risk we have to counsel our patients about. And the most common complication, according to that same study, a staggering 69% of phakic eyes, so eyes that still have their natural lens, will have significant cataract progression after the oil comes out. For these patients, it's really not a question of if, but when.
Intraocular pressure is another big one to watch. Post-op, you can see both spikes and drops. About 7.5% of patients will get hypertension, while almost 4% will face hypotony. This means we have to be super vigilant in the weeks after surgery. But let's end this section on a really crucial positive note. Because despite all these risks, the data is clear. That same Zhao et al. Study found a statistically significant improvement in overall visual acuity. When it's successful, SOR works, and our patients see better. Plain and simple.
So we've gone over the why, the when, and the what-ifs. Now let's try to distill all of this down into a practical checklist of key surgical principles that you can take with you into every single SOR case.
So what can you do to stack the odds in your favor? Well, the evidence points to a few key things. Doing a prophylactic 360-degree laser treatment, having a scleral buckle already in place, and, like we talked about, that longer tamponade duration, all of these have been shown to lower the risk of redetachment.
In the end, success really comes down to being thorough. It's a mindset. You don't just suck out the main bubble and call it a day. You have to meticulously perform those fluid air exchanges, you have to hunt for those sneaky globules hiding behind the iris, and you have to do one last careful inspection for any new or missed pathology.
And that brings us to the final and I think most critical question. We have brand new data from 2024 telling us a longer tamponade is safer for the retina, but we also have all this older data telling us that a longer duration raises complication risks like band keratopathy. So for your next patient, sitting right there in your clinic, how are you going to weigh these competing risks? That right there is the art and the science of what we do.